Hello, everyone. Welcome back to today, or I should say tonight. Welcome, everybody. I hope everyone's doing well. We have Dr. Wynne Huang that's about to set up her stuff, and this is Dr. Fefferman that's joining us today. So, everybody, thank you so much for the ones that are going to start to join us tonight. Today, we are having November is Pancreatic Cancer Awareness Month. Why do we call this one silent killer? And what makes early detection hard? I'm not sure, but we're going to find out by the great Dr. Fefferman and the great Dr. Wynne Huang. And we have a guest that's sitting hidden away from it all. Cece's here, who usually writes something. So here we go. Let's just start out. So welcome aboard, Dr. Fefferman.
Thanks for having me.
Dr. Huang, always a pleasure to see you. So please, let's just start right off to the bat. So tell me a little about yourself, Dr. Fefferman.
So I'm a general gastroenterologist, which means we deal with everything from diseases from the mouth all the way through the other end, including liver and pancreas, which are digestive organs, and all the diseases that come along with it. And so November is Pancreatic Cancer Awareness Month, and
yes, we
there you go, and the purple ribbon.
Thank you.
And there's a couple great organizations, the Pancreatic Cancer Awareness Network and the Pancreas Foundation, and those are some great resources. But pancreatic cancer is a really tough cancer. It's not the most common cancer. In fact, it does make the top 10, but it's towards the bottom of the top 10. But when it's diagnosed late. And a lot of times people get really sick from it, and there's a high mortality rate. So finding it early is really important, because if you can find it early, there's a much better chance of doing well with it.
Okay, so one of my questions is, before Dr. Huang starts to yell at me about something. So hello, everyone. Remember Dr. Huang over there? So one of my questions is, why do we call this one the silent one, and like a silent killer, and what makes it so hard for it to be detected?
Yeah. So, with certain other cancers, we'll use, for example, lung cancer. People oftentimes will develop symptoms that are easy to kind of pinpoint. Someone says, I'm short of breath. I'm coughing. I'm coughing up blood. But in pancreatic cancer, the symptoms can be really vague. So it could be that they have some vague stomach pain. And it's not easy to put your finger on exactly where it is. There may be some loss of appetite or some mild nausea or some weight loss, but there's not one symptom that says, aha, this is pancreatic cancer. So the symptoms can be vague, and by the time it does present with really defined symptoms, it can often be late. So that's why it's a silent killer. It's really, the symptoms are pretty vague until it can be late, until when you show up and you've turned yellow. So turning yellow is one of those obvious.
So when you're saying turning yellow, meaning your skin or your eyes?
It could be both.
Really?
Like a highlighter.
Like a highlighter. So
really,
it's called jaundice. And sometimes people will show up without any pain. Maybe they've lost some weight, but it's been slow and gradual. So it's not been something obvious until they turn yellow or jaundiced.
See, I always thought that was like, so I've always been blindsided, because working in the prison system, they said if you see someone like that, then they're probably alcoholics.
So alcohol affects both the liver, and it can affect the pancreas. Alcohol can also do damage to the liver and can also result in liver dysfunction and jaundice, which is the yellow in color. But pancreatic cancer, when it grows slowly, it can actually block the bile duct, which is the tube that drains the liver, and people turn yellow because the liver is being blocked.
All right. Well, I was going to ask you, medically speaking, what symptoms are most often looked over, and you just answered it.
That's some of the things that's hard in bringing some awareness is that if you're over 50, because that's when most pancreatic cancers occur, after the age of 50. But if you're over 50 and you have these even vague symptoms, you should be seen by your doctor, especially if they're ongoing. If they're there for a couple of days or a week, no, it's probably a little early. But if symptoms persist, you should talk to your doctor about it.
Okay. So Dr. Huang, it's funny because he said you should talk to your doctor about it, and that brought us right into a question I needed to ask you.
Okay. Shoot. I can handle it.
You sure? because I do get scolded afterwards by you saying, why didn't you set me up for this before I came on?
It's a
So you
softball.
ready? Yeah, you ready? Here we go. Here's the handoff. Dr. Huang, do you think internal medicine and primary care miss early warning signs because they focus too much on labs and not enough on the patient's gut health?
I'm a little confused by that question. Um,
Well, the reason why I had brought that up is because obviously my two uncles had pancreatic cancer and they went through the Whipple. And when I started research and stuff, as you know, I started to research. One of the most interesting thing that I found out about pancreatic cancer is when you said there's certain signs of it that happens. One of the top signs always seem to affect the gut health on its own. So meaning they have issues with their gastric, acids or whatever that's happening, something's going on in the digestive system that probably could have showed signs for this. Is that incorrect on this? Because the more I
are you
looked
saying like
into it,
amylase and lipase?
yes,
You're asking specific about amylase and
yeah,
lipase.
well, other stuff that's in the
Well,
gut
well, I
too.
guess, and Dr. Fefferman can talk about this more, but if your amylase and lipase are elevated, that could just be an indication of pancreatitis. And if you have recurrent cases of pancreatitis, that itself can put you at risk for developing pancreatic cancer down the road. But then I also think that, like with the liver, sometimes you can have falsely normal levels if there's been enough damage that the cells aren't going to produce those enzymes. So they may not be picked up on the blood test, right?
Yeah, I mean, again, it's very vague. You can have symptoms of indigestion as an early sign of pancreatic cancer, but most of the time that's just heartburn, reflux, indigestion symptoms. It's
Okay.
not necessarily pancreatic cancer. One of the things I didn't mention is a new onset diabetes. That can also be especially after the age of 50, especially in someone who's losing weight, someone who's not heavy. Most diabetics are gaining weight.
So that was the case I was going to mention.
There you go. Maybe that's a segue to even talk about it.
So I have a patient who came in, thin guy, big history of smoking, big history of alcohol. I mean, he almost died from it. He was in the ICU and intubated and everything, like while his pancreas was healing. But anyway, he's in his late 50s and didn't have any issues with his blood sugar. His A1C was 13 last year. So new onset diabetes. So I'm looking at him. I'm like, new onset diabetes, big smoker, big alcohol user. I mean, he's since been sober, but I'm thinking to myself, I would like to screen this guy for pancreatic cancer. But is insurance going to cover this?
So
and what would I do?
Yeah. So we have to always work around insurance, and insurance usually wants a certain set of symptoms that raise enough of a suspicion that they say, okay, this warrants doing a CAT scan. So the new onset diabetes by itself is probably not going to warrant them saying, yes, you can do a CAT scan. But there are other things like weight loss,
right?
Or adding the weight loss plus new onset diabetes, and those are potential risk factors.
Maybe I should back up for our viewers so they understand. So the idea is, if you have new onset diabetes, is it possible that there's a cancer in the pancreas that is then affecting how your islet cells in your pancreas are working? So then they're not producing enough insulin. So is it the cancer causing the diabetes? Or so that's what we're thinking.
Yeah, and I guess I'll take a step back and say, so the pancreas lives kind of right in your mid-abdomen, and it does a couple of things. Number one, it produces some hormones that control your blood sugar. So if that's not functioning correctly, you either develop diabetes. So the hormones that it produces are insulin, another one called glucagon. Insulin when your blood sugars are too high, and glucagon is a hormone that's produced when your sugars are too low. It's basically your body is able to kind of rebound and say, hey, your sugars are too low, let's increase them. And so that makes that hormone. And the second thing it does is make some digestive enzymes. So if it's not functioning and you develop diabetes because it's no longer able to make the proper amount of insulin, then yeah, it's a sign that your pancreas isn't functioning. However, most diabetes, meaning like 99% of new onset diabetes, is not pancreatic cancer. It is just that your pancreas is no longer able to make enough insulin.
But I think if you have those risk factors, age over 55, history of smoking, alcohol use, which as a primary care doctor, these are when you were talking about when someone comes in, modifiable factors. So limiting drinking, limiting smoking, controlling your weight. is very important. Anytime there's excess weight, it causes inflammation in other parts of the body, and also your nutrition. So eating cleaner foods, less, I mean, maybe you could speak more about that, less processed foods.
So that one's a little harder to determine. We know that people who live as cleanly as, I'll put quotes around that, cleanly as possible, they still develop cancers over populations. Yeah, people who eat better, healthier, lead healthier lifestyles certainly have less cancers. But smoking, for sure, that is probably one of the highest risk factors. Alcohol, especially if it causes recurrent pancreatitis. But obesity is associated with a lot of metabolic dysfunctions, as well as it's probably one of the greater risk factors for almost all cancers.
So it's funny that you brought up alcohol. So I'll bring in a personal story. I was a heavy drinker. I used to love my Jack Daniels. For those that are going to watch, that know me, I used to love my Jack Daniels.
Did you love your Jack Daniels?
I love Jack. I love Jack Daniels so much. I used to call him by his first name, John. Okay. I used to drink so much of it. It was like I would literally finish off a handle.
Yeah.
But I was also, at the time, I was a big guy. I was into heavy lifting, doing shows and stuff. I was 290 pounds. I ended up with pancreatic
Pancreatitis.
Pancreatitis. It went away, came back, throwing up blood, the whole 9 yards. And then I decided to stop drinking.
Yeah.
So after I stopped drinking, they did a, what was it? MRI. They found out I had a cyst on my pancreas. So now we have to watch it every year to 2 years and stuff like that. Now, obviously, you don't know my history, but do you believe it was from the alcohol?
So probably. We know that pancreatitis causes inflammation, and that inflammation, as it heals, just like everywhere else, if you have inflammation when it heals, it doesn't usually heal back completely normal. You may get a scar. In the pancreas, you may actually get a little fluid-filled cavity that where that tissue is inflamed, it may actually, those cells die and may create a little rim or a cyst or a cavity, and it may fill with fluid. So those are called pseudocysts. And for the most part, those are not associated or have a significantly increased risk of pancreatic cancer.
Yeah.
There are other benign cysts as you get older, again, after the age of 50, that you can develop small cysts in the pancreas. And in fact, they're really common. People come in.
Is that called marriage? I'm sorry. I was just asking.
Okay, let's talk about how lucky you are that then you met your future wife, who's a family doctor, and suggested that you get genetic testing done because you had 2 uncles with pancreatic cancer.
Yeah, but
how about that?
Well,
Give me a high five.
I'm glad I'm sitting.
Don't leave me hanging.
I'm glad I'm sitting in the middle.
Yeah, but I got diagnosed with it 15 years ago.
Yeah.
So I don't understand where you came into the picture.
Because then I said, "Oh boy, you have a history of
no,
pancreatic
she brought all these boxes to a family party and said everyone swipe." I go, okay.
Everyone's getting a swap.
That's what it was all about. You got free boxes.
Yeah. So when it comes to family history, and maybe we can, if you want to share your family history.
Oh, absolutely.
But 90% of pancreatic cancer is not associated with a family history.
It's not associated.
It's not.
90% is
really
one-off. The body just makes a mistake. It makes an error. Yeah. Then maybe 10% of it is associated with some other risk factor, chronic pancreatitis, and a really small amount is due to actually a known genetic factor.
I didn't know that.
Yeah. So
wait, I protest though.
Oh, please.
So I offer a lot of genetic testing in my office, and when I was looking into this, I thought that the BRCA2 gene mutation could increase your risk. The normal lifetime risk of pancreatic cancer is 1% of the normal population. But I was looking, if you have the BRCA2 gene mutation, it can be up to 10%.
Yeah, so definitely. So we know that there are genetic factors that increase the individual's risk. But if you took 100 people with pancreatic cancer, 90% would have no risk factors whatsoever, no family history. No family history. It's just a one-off. It's not a genetic factor. Genetics probably makes up 3%.
So 5%. My family must be 3% because my uncle got it.
Yeah.
Then his brother got it a couple of years afterwards. And then I'll be honest with you, if it wasn't for Dr. Wynne Huang, me knowing her, God bless everything about my family. I'm very close to them, that they survived, but it was because of her suggestion that they went through a thing called the Whipple.
Yeah.
And the surgeons did an incredible job, and God bless. they've been incredible.
Yeah.
You know, they've been incredible.
So,
So-
the BRCA gene is the most common gene found, and we'll say that the baseline risk, lifetime risk of pancreatic cancer is about 1%. So no one with a family history, just your baseline risk. If you carry the BRCA gene, which is mostly associated with breast cancer and ovarian cancer, the risk can be anywhere from 2 to 8%. So 2 to 8 times, and it really depends. So when we look at people who have,
So is it more females? And I'm sorry for interrupting. You're
No.
saying breast and ovaries.
So, and
so I'm
prostate
thinking.
BRCA can actually also
Yeah.
be affiliated with prostate cancer.
Oh, okay, but you're saying breasts, could males get it too because they have breasts?
So anyone can carry the BRCA gene.
Okay.
It oftentimes most shows up in early breast cancer, early ovarian cancer.
Okay.
Prostate cancer is a little bit slower, but it's still a risk. But males can carry it. Males can get breast cancer too. So if there's a family history of early breast cancer, it's pretty standard of care right now that if you have early breast cancer in your family, or with most breast cancers, they're actually checking you for the BRCA or BRCA gene. And there's a type 1 and a type 2. As far as it relates to pancreatic cancer, the BRCA2 gene has a higher risk. But again, if the baseline risk of everybody is 1%, BRCA might be 2%. If you have BRCA gene and a family history of pancreatic cancer, then the risk goes up even higher.
Okay.
So, like, let's say, for example, that your mom, and thank God she doesn't, but let's say she had the BRCA2 gene mutation, and now you have uncles who are her brothers have pancreatic cancer. So that would be like, oh, we should definitely get you tested to see if you have any gene mutations, because you got a lot of risk factors going on there.
Yeah. And nowadays, what they'll do is, instead of saying, let's look for one gene, they will do a panel. They'll look for 46 different genes.
Yeah.
They'll look at your family history and say, okay, there's some breast cancer here, there's some colon cancer here, there's ovarian cancer, there's pancreas cancer. Let's just do a whole panel, because it's oftentimes hard to figure out what gene abnormality there is, because different gene abnormalities can affect the cancer pathway in different ways. So they do a huge panel of labs, and they identify a genetic abnormality. And we can go into, do you know if he?
Huh.
We did the genetic
Okay.
testing. He was negative. So I'm just going to do a shout out. I personally use Natera in my office, and it's fantastic. They can actually do up to 81 different testing mutations. You can do blood tests, really easy, or you can do saliva if you don't want to get poked with a needle. And it's so simple. They will even ship you the kit to your house if you want.
That's great.
Yeah.
Yeah.
Nice.
So we usually recommend, if someone has cancer in their family, that the person who has the cancer should be the one who's tested. Because
So test the one that has cancer.
the one who has cancer.
Really?
Yeah. Which
Was it give you a baseline or something?
so if the person with cancer is tested and they don't have a genetic abnormality, then their siblings don't need to test, their kids don't need to test, so the rest of the family doesn't need to test. If you don't have the information, so you say my dad passed away from, you didn't, but my dad passed away from cancer.
Mine did, so I wouldn't
Yeah.
know. Well, I don't know what he passed away from, but
Yeah.
he was old.
So if you don't know, then
Wait.
then
Guess how old his dad was. Wait, guess what year?
Mom, I know
Guess
you're
what
watching,
year-
so
guess what year-
your daughter-in-law over here is ratting you out.
Guess
Yeah.
what year? Guess what year his dad was born?
well, I'm guessing if you're asking it that way, I'm guessing he was he was an older guy. I'm guessing he was an older guy.
Like, he's an older guy. Good. What year was he born? Since you got
1900.
1900,
Get
my old
out.
man was born. He's a beast.
I saw the tombstone.
He's a
Yeah.
beast.
1900.
Yeah.
So
Wow.
anyway,
Yes,
so
yes,
no,
yes.
didn't
But
know.
he had a lot of issues.
Yeah, and
You
they
know,
didn't do
health-wise.
they didn't do testing back.
Yeah.
then.
He had diabetes.
back in the early
all that.
1900s.
Well, 1970, but go
Yeah.
close enough.
Yeah.
Yeah. It was close enough. So let me ask you something. So I want to keep discussing this, but because now, and especially listening to Dr. Huang when she's doing so much with these products, I wanted to discuss
products?
something about like the hormone balance,
Oh.
metabolic health,
Yeah.
and balancing hormones that could actually prevent, right, something like pancreatic cancer. Or is this an overreach in your field? And
Well, we know, again, obesity causes a lot of metabolic disturbances and causes a lot of health issues, whether it's heart disease, it causes a lot of different things. And so there's a huge focus on weight management, living a healthy lifestyle, and we're finding through the use of like the GLP-1 or the injectables.
See, you're like Dr. Huang. I was going to bring that up right away, right to it. Let's just stick with the obesity part right now, Dr. Fefferman.
Yeah. So obesity is associated with a lot of different bad health outcomes, and
and I do apologize for this. So I got a question for you. I find it funny because I'll go in and see my doctor, like not right now, but
interesting.
Okay, but I find it funny.
Okay.
So I walk in at 280 pounds. I'm 6.3 body percent fat.
Oh gosh.
But yet my BMI is I'm not saying now, I'm saying back then. And I'm fat.
Yeah. Well, you have an elevated BMI. So it puts you in the overweight category.
Morbidly.
Because of the size, but not the fat.
Yeah, it's an imperfect. It just takes your height and weight and creates a ratio for the majority of people. And again, at that height and weight and body fat, you're an outlier. So it's meant to capture.
I don't even know what the hell that means.
It means that you're not the ordinary individual.
Oh, all right.
Yeah, you're not the regular guy.
Yeah,
you're not the regular.
Yes, I've learned a new word today. Outlier.
Yeah, you're not the regular guy walking down the street.
I always get thrown off on that and how you make that judgment, and you just said it again by BMI, and I could see people that are shredded, and they're all like, they just told me that I'm fat, and I'm like,
it is
I'm
not
sorry.
a good system. It is not.
That's not a good system.
Yeah. But unfortunately, that's what insurance companies use to base diagnoses and decision making on.
Okay. So since you jumped the gun, and I'm gonna move on because I know Dr. Huang loves this. Is GLP-1 drugs like Ozempic, Mounjaro
technically
are
Mounjaro is a
exploring.
GLP-1 and a GIP.
There you go.
Thank you, Dr. Huang. I don't even know what that means, but let's just say, do you want to explain what GIP is?
Glucagon inhibiting peptide.
I think so, yeah.
Yep.
Do you think so? Or do you know?
No, we know. Glucagon inhibiting peptide.
All right. So in Mounjaro exploring popularity, right? Some studies suggest possible links to pancreatic issues. Do you believe long-term GLP-1 use could raise pancreatic cancer and risk?
So I haven't seen any studies that show that it increases pancreatic cancer. Rarely it can cause some pancreas stimulation and irritation and pancreatitis, but
I said pancreatic issues.
Issues, yeah.
But does it have pancreatic cancer risk?
I don't think so. Not as far as we know now.
Okay.
But it's something they'll certainly be keeping
Find that
an eye
interesting, Dr. Pfefferman. Now.
Yeah. Well,
Okay.
You never know.
Dr. Huang, any input on that? Because I know you've had patients inquire about that.
Well, we do say before I start anyone, I say that, the big no-nos are, if there's any family history of medullary thyroid cancer or family history, but we do ask if there's family history of pancreatic cancer or recurrent pancreatitis, because I guess if you get enough irritation in the pancreas, that would put you at risk.
Yeah, I mean, chronic pancreatitis or recurrent pancreatitis over multiple episodes is a risk factor. And also you're interfering with the pancreas and you're stimulating the pancreas. So there's anytime you set off the pancreas, it's probably not a great
and that was going to be a question of both of you. When you had said that the stimulating, does it cause pancreatic inflammation as one of the causes with the GLP-1 usage?
It can. It's rare, but it can. So if people are having symptoms after starting, that's something they should alert their provider.
So Dr. Huang, that's a question for you also. So now how would they know they having it? Because we know people that are on it feel nausea and feel dizzy, or they feel like they got to throw up. So these are all the things that happen from GLP-1. You hear it all the time. And then they curb their appetite. The weight loss is supposed to be a product of that for the usage. So how would you make that determination? Is it like, we're going to test you for every 30 days for being on it? Or do you just say, well, how does it actually work?
I would say, and Dr. Fefferman can chime in, but I would say if they're having pain in that area where he said, like, right below your sternum across, and it's usually like you feel like you would be able to share, but like a knife going right through, I would probably just do blood work and amylase and lipase and confirm if there's inflammation in the pancreas. And if that came back normal and I was still concerned, then I would do imaging, because like I said, you could have falsely normal levels.
Yeah, I agree.
Okay. Thank you. But you had said I could tell you, for those of you who have never had it, it feels like a broad hot iron hitting you in the stomach and burning and burning. And then you would switch to another side, it would go away. But then all of a sudden you would feel it on the other side, and it hurts so bad. There is no position to stop the pain. It hurts that bad.
And it feels like it's going straight through.
And it can even be just back pain. You could say, I have no pain here. It's something in my back.
Yeah.
Or it could go from the front all the way through to the back.
I had it my lower right side of my belly button going right to, and then I would switch the side to try to sleep, and it would go through. And then what I used to do is get up and do more shots, thinking it would put me to fix me. So don't listen to my medical advice. No shots.
I didn't know you back then.
No, you didn't. You wouldn't have liked me back then. So since we're going down that path, and I know Dr. Huang brought this into her practice. So one of my questions is this, and I think you both should have inputs on this, is Dr. Huang, you work with TRT and hormones and testosterone, DHEA, estrogen. Can these treatments affect the pancreas and the liver if misused? Obviously, I know from being an anabolic user that I think if you're not underneath the proper medical care, that it leads to abuse, and you got to watch out what you do. But what do you feel about that?
If they're on too high of a dose of their hormone replacement?
Well, I'm just saying any type of usage of those products.
Hormone replacement?
Yes.
Well,
so testosterone, DHEA, estrogen.
Mean, right off the top of my head, I'm going to say no, because when I'm treating patients, I'm supplementing levels that are low and trying to get them to normal or optimal ranges, not super optimal. So I'm just trying to help them get back to where they were like 10 years ago. So I'm not,
so one of my questions, and I do apologize if it's misused. So meaning before they see you. So what I'm trying to say is basically they need to see somebody as you two. If they want to go down that lane, you should get medical advice and find the right doctor that basically tells you what to do and how to do it.
Mm-hmm.
So I'm saying the misuses of it, will it affect the pancreatic?
Well, I suppose high testosterone levels. I mean, and that's never a great thing. If you're I know some men get a little carried away and they want their test levels like at over 2,000, which, my range is like 800 to 1,000. But I guess I don't know how to answer that because I'm always like normal or like optimal.
Mine was never to get the test level up. It was just to get the size off it.
So that's
so it was. I couldn't know what my test levels were.
In physiologic, meaning for 95% of people, where you're shooting for and I don't, not a specialist in hormone anabolic steroids, but if you're shooting for the physiologic, basically normal ranges, it is it is safe, but it can elevate things like your triglycerides, which are fats in your blood. And certainly we see people who are using it for muscle gain, which is outside of, we'll say, I'll put physiologic, meaning normal, healthy, muscle stability and muscle growth. They're looking for gains above what is considered kind of physiologic or normal. But they're looking for their own personal reasons. And there can be some health risks associated with it. You can develop fatty liver and triglyceride issues, and elevated triglyceride can be a risk factor for developing pancreatitis. So there are some risks associated with it. But again,
I agree with that. I agree with what he said.
You had said fatty liver. Is that reversible?
So fatty liver is a huge, the answer is yes, it's reversible. And that's a whole other topic we could talk about, but yeah. So
I had it, but I don't anymore.
Anyone who carries extra weight on their body, all of that energy got into their body through eating calories. And if you're looking for gains, you're going to you need excess calories.
Yep.
So all of those excess calories need to be converted from whatever you eat into what we use or what we store for later. And it gets stored and converted in the liver. And sometimes our body can't convert it fast enough and get it out to store on our fat stores. So it gets trapped in the liver. So fatty liver develops, and that can be a risk factor for liver disease down the road. But it's reversible. Your body is able to burn those fat globules, which get trapped in the liver over time. And
so listen, if Steve's watching, shout out to you. You can get rid of fatty liver.
I think Were you nervous to say there is a small chance that fatty liver can become cancer?
So fatty liver,
Wait.
yeah,
I
no.
noticed that you didn't say the C word. But
So
there,
fatty liver over time can cause inflammation because it's fat that doesn't really belong in the liver in that degree. As those fat globules break down, the body is breaking them down and causing some inflammation as it gobbles up the fat to try to get rid of it. That chronic inflammation is a risk factor for scarring and cirrhosis, and that actually can be a risk factor for liver cancer.
Oh, okay. So I kind of wanted to stay in the same network of the group there, because now the biggest things that are happening are those products that are coming out. But also, when I was doing some research on it, what's your take on patients self-prescribing peptides or hormones without supervision? Could they be stressing the pancreas without realizing it? Because peptides now are ended up being big. That's all you're seeing. If you're on Facebook or any other thing, they're popping up.
Yeah.
And I'm also seeing advertisements of pancreatic things coming up right behind it with like medical stuff. And I'm like trying to put both of those together. Is that an
are
effect?
you asking about glutathione?
No, I'm basically talking about Sermolin, NAD. I'm talking about the glutathione also. I'm talking about any of those products that are being processed out through your pancreas and being filtered out. So I've been watching commercials, like if you have a peptide commercial or it pops up on Facebook right afterwards, that pops up. So is there some type of
We talk about precursor hormones. We back in the not anabolic world, but precursor peptides.
Precursors. So move on for that.
Yeah. Anytime you're doing so, my kind of feeling is life is about moderation. And if you're living in moderation, meaning eating a healthy diet, exercising in moderation, alcohol in moderation, all the things are probably fine. When you do anything to excess, even driving your body to build muscle, yeah, it's healthy, but at some point, there's a point where you say, I'm doing this, and it's not necessarily the healthiest thing, whether you're putting on a lot of weight or putting on a lot of muscle mass. It's not necessarily the healthiest thing. It may be an aesthetics thing, which is a decision one makes. And to get certain gains, you may be doing, certain things to put on excess gains, which your body couldn't do alone. I'd put that in the slight excess category. And we all know from seeing people in the news that are young, healthy, very fit, either bodybuilders or people in sports who don't live a long time.
Yeah.
They run into health issues because they push their bodies in ways maybe it wasn't developed to be pushed. So
I don't know if you know this about my husband, but he actually used to own a nutrition store, and he actually knows a lot about vitamins and nutrition. So I'm going to ask you a question now. I'm going to turn the tables. So do you think there is a difference, which you were mentioning the peptides, oral versus like sub-Q injection? Because I'm thinking in my head, anything that's oral, there's an increased likelihood of it going through the liver, pancreas, like the first pass. And so, for example, I would never, ever prescribe oral estrogen to a woman because there's just too high risk with the liver and everything, increased risk of blood clots. So, but it is more reasonable to do like a cream, pellet, topical. So I think that the question is the difference in administration as well. What do you think about
Well,
that?
I think you answered the question on your own. So as you stated, I'm against any type of oral products anyways, unless they've basically been binded together correctly by herbs and stuff like that. I don't like synthetic products. I don't want my body to process through it. I always go by the key thing is, and when I go and pee, I want it a tint of yellow, but not dark yellow. And then all of a sudden, if I know it's dark yellow, I know that product's junk and I'm not going to do it because now my body's processing it way too many times to break down the nutrients and trying to find a binder so it could bind to it. So I know my body's flushing it out. So I absolutely agree with you. Would I pick a sub-Q over doing an oral? Absolutely. But I think people aren't educated to understand how to shoot a sub-Q and understanding the correct way. Like people that do testosterone should go upper thighs, and shoulders. Instead, people will go on the gluteus maximus and upper, hit a nerve or a vein. So I think it's through education with you two and understanding. If you're going to make that choice, you need to speak to your doctor and you need to say, I'm making this choice. And it doesn't matter if you're with me or not, I'm still going to do it. But, keep me healthy. So if you're asking me, oral, sub-Q, I say
Right. No,
sub.
it's just saying because when you ask the question, it's like I guess there's different facets to the question. Like it's not just is NAD good or bad or Somorelin. It's like also the method of delivery.
Absolutely. And I also, and I hate to put you on the spot with it, but I totally disagree with testosterone creams or patches.
Well,
I just think because you have to move them site to site and they only work for so long, unlike sub-Q where you can microdose and
no,
get what
I
your body
agree with you,
needs.
but I like to be able to provide
Dr.
options to my
Fefferman's like,
patients.
what's this pancreas on
So are you natty or not? No, I'm just kidding.
Not, but I'd like to be natty again. I can't. So listen, it's pretty interesting because as we're all discussing this, and when, one of my questions would be, obviously I was able to do it, and I know a lot of other people. Sometimes it's a fight for people to just stop things like cold turkey and doing things like that. But if someone doesn't want to stop drinking or someone doesn't want to stop using, I think it would be the wrong advice if you were to tell them, well, you know what, you could take a little of this but not that or this and that. How would you handle somebody like this from a professional standpoint?
So we see people all the time who have either liver disease or pancreas disease, and they struggle with it. It's something that they've come to rely on, and the key is giving them support. Again, everyone in the end makes their own decision. You can lead a horse to water, but you can't make them drink. But by educating them and making that person, or educating that person, or showing them something that when it is their time to make a healthy decision, that they're able to do it, and they make it on their own. You can't make someone make a decision if they're not ready to. But educating them and supporting them.
Dr. Huang?
I completely agree. So it's interesting. Back in the day when when I was a medical student in the 90s, and we were talking about we would talk about motivational interviewing, and then if someone's not ready to make that change, we don't continue to like berate them. They're not ready. We talk about different stages of change. So are they pre-contemplative, meaning it's not even on their radar, like they're going to keep drinking, or contemplative, like they're thinking about it, and then action, so they've stopped. So just like Dr. Fefferman was saying, being supportive at whatever stage they're at.
And then sometimes there's even those midway things where someone says, I'm going to try, but I want some accountability. And there are some medications, and again, I'm not in this is not my area of specialty, but there are medications, if they do slip, there's a negative feedback. And again, they may have to take a pill that says, if I mess up, I'm going to feel lousy. And their brain just then makes a connection. You know what? This doesn't feel good anymore. I was doing well, then I slipped up, and now my body's telling me I don't like it. I'm feeling lousy. So it kind of helps reinforce it.
So just to let you know, my story was I had a doctor named Dr. Huang also.
But
but but it wasn't you. It wasn't you. She met him. I wasn't going to bring up what happened between you and him.
But I walked in, and let me just tell you, he was like 6 feet tall, and he's white.
I'm not going to lie.
All right.
Dr. Fefferman, and this isn't out to anybody because obviously I'm married to an Asian female. I only picked him because I was like, I need an Asian doctor because they're so smart.
There you go.
So I picked him, and then I said, wait a minute, you look Irish. And he said, my great-great-grandfather's Chinese. That's where I got the name. I says, okay. But when I went and saw him, he said to me, quote unquote, you're an idiot. I'm not asking you, I'm telling you, and slapped me in the head.
Did it work?
Yeah, it did.
Okay. Sometimes it does.
I said I didn't want to get scolded by my doctor again. So he backhanded me hard.
Well, sometimes, if you have that relationship with your doctor, and that's the key, is find a good doctor, you have a good relationship, and that person, if they're a people person, they can sense who you are in that relationship. If you can tell somebody a little bit more about, like, what are you doing? And other people,
I'm not
they don't want to be talked to that way.
There's a little more to the story. And he basically had said, and put on a pair of rubber gloves and said, if you want to come and see me once a week and you being an idiot, you get this treatment.
Yeah.
And I says, okay.
You said,
away.
I'll be here.
Yeah.
Yeah, I did. And I said, no cream next time.
Oh.
You want to go there? Felipe can go there. So let me ask you both something. So I found this pretty interesting. Is there a connection between metabolic stress, like insulin spikes, cortisol, or synthetic hormones, and long-term digestive inflammation? I know that was a lot.
Yeah,
I should have
it's a
just did
lot.
it. So it's just because I wanted to discuss a little more about metabolic stress on the system.
So the answer is yeah. We know that any stress, and stress comes in a million different forms. We know that people who exercise a lot or push their body to excess, it's tough on the body. And yeah, there are injuries. If you said I have an overuse injury from lifting, or I was trying to get gains and I tore muscle or tore ligaments. But on the GI tract, there's that same stress.
I'm sorry. So you're saying tears in muscle could cause that?
No, I'm just saying. I'm just saying. Yeah. Overtraining anything can lead to injury.
Okay.
And overuse of anything, including overstress in your body, whether running ultramarathons. There are some long-term health issues, not only joints, not only muscles, that that show up in long endurance. There's a lot of benefits, but there are also some downsides to it that can show up later. It's not a major risk factor, but yeah, there can be stresses on the GI tract from overexertion.
Dr. Huang, it looks like you're patiently waiting to say something to that.
No,
Feel free. The hands are closed. You're ready. Go ahead. Draw. Shoot. Say something.
No, I completely agree.
Damn.
I
thought you were going to say something.
I actually, in the back of my head, was thinking, because I love to eat, and I was thinking about if when I go to the all-you-can-eat places, that's like stress on my GI system. That's actually what I was thinking.
So I think once a week.
Cece, help me out with this one.
Probably not.
Can I just get translation, please? What the hell? I'm totally lost.
I was just thinking about
all you can eat sushi.
Like when I go to Maki and I do like my all you can eat sushi, like, and my body's like, No,
I see you stressed out when there's too many sakis to pick from, and you're like, oh my God, what sake should I get? And I'm like, I don't know, I don't drink. Oh, that's interesting. So one thing that I was researching and reading about, they were talking about fasting and detoxing.
Yeah.
Is that good for the pancreas? Or is it stressful?
Go ahead.
No. You mean like a juice cleanse, like when people
any type of detox? Like I have fasting that does an internal cleanse out, and then you slowly integrate back into your system juices. Then you slowly bring in fibrous carbs and not complex carbs, and then you slowly bring the stuff back. And it says it detoxes, because from what I was researching back in even biblical times, that the reason why we're so sick is because we eat too much. And back in the days, you didn't find this type of disease because people only could afford to eat one meal a day, if that.
They didn't have all you can eat sushi bars.
Well, that's what I was going to lead to. They didn't have as many times going up to get matcha.
And you had to run up. You had to chase after your food for 4 hours.
Exactly. Oh my God, there's a flat noodle and a round noodle.
So are fasts good? I think there are some people that really strongly believe that you should be fasting 16, 18 hours a day and eating one meal. There are some longevity specialists that they think that one meal a day is how you should be eating, or or some people eat seasonally, like as they eat only during the day, and as days get shorter, they do longer fasts. It does, when you do fast, you do burn this stored energy in your liver. And is it really a detox? I'm not sure that's the right word, but it does do some house cleaning during the fasting process.
So you're obviously somebody that knows about it, because that is the number. It's 16 hours. So it's 12 to 16, but 16 is when your body fully detoxes out and gets rid of all the toxins internally. So that's pretty interesting that you did say 16 hours.
So you do have, a certain number of hours of sugar storage or glycogen storage in your liver. And after that, your body goes into a ketosis and starts to break down energy slightly differently. And, some people say that they start to feel better when they do that. And then once you get used to that, some people say they thrive on it, and some people eat once a day, or some people eat once every other day, or they do this intermittently, where they may eat once a day or twice a day, and then every couple of weeks they'll do a longer fast. again, I'll go back to everything in moderation. There's some people that thrive on that, and some people that say, oh, if I don't eat a small meal every 4 hours, I'm hypoglycemic, or they have some symptom of I'm feeling a certain way. I say you got to listen to your body.
Yeah.
From athletes, we know that some people they're able to eat one way and get, real benefits, and other people, they say, I have to eat this way. This is the way my body thrives. So listen to your body.
Dr. Huang's story. So when we
Oh,
decide
God.
to detox, I get these juices. I didn't realize Dr. Huang's fasting, which you would have 3 to 4 of these juices that I paid a lot of money for, that in the middle of it, she's actually eating food. So she would drink a bottle, then go to work and order lunch. And then I would be like, oh, she goes, what are we having today? I'll be like,
Juice
green juice.
cleanses.
Green
Yeah,
juice.
sure.
She's like, oh my God, I've been starved all day. And then I started realizing when she would empty her bag of food, there would be extra. And I'd be like, hon, did you eat this? Oh, well, I had to take a few bites of it. I go, you're not fasting then. Oh, but it's okay because I only ate a little of it. Now I'm going to eat the green. Then she became to 1 bottle in 4 meals, and then no bottles, and then so on and so forth. But that was her fasting. How did it work?
Well, and I sleep like 8 hours a night. So couldn't that just be
10.
considered my detox time?
That's,
Okay.
Yes. Okay.
yeah. That's one thing that sleep's important, but I
Cortisol, maintain your cortisol, insulin sensitivity. Sleep is
How would you maintain it?
By sleeping enough. When you don't sleep enough, it puts stress on your cortisol, rises, and then you have increased insulin sensitivity.
But how do you know it's not enough? Like I sleep 3 to 4 hours and I feel great.
You look at your sleep app machine and it gives you a smiley face.
Says I'm the bomb. My sleep app machine says I'm the bomb.
Okay.
It says well rested.
Yeah, everybody's different. Some people thrive on 3 or 4 hours. Some people need, 8 to 10 hours. And,
Exactly.
I'm glad I'm sitting between you guys.
There's nothing to sit in front of. Listen, this is an ongoing battle. That's it. So, Dr. Huang, floor is yours. Any questions or anything you'd like to ask?
Any question? Oh, I know. So let's get back to, because real world stuff. So my patient that I brought up, ideally, new onset diabetes in his late 50s, big smoker, big, history of alcohol use. And I was like, should I try and get insurance to order imaging? And would that be MRI of his pancreas? And this is just so frustrating because if I probably have a lot more other patients with the same story, weight loss, new diabetes, and I would like to do that. It's very frustrating.
It is. I think you got to listen to your patient, and patients, you need to be an advocate for yourself. If something doesn't feel right, talk to your doctor. And if it's still not right, talk to them again. On our side of the fence, oftentimes we'll order a CAT scan. If someone's over the age of 50, insurance, and it's an arbitrary line at 50, but usually after the age of 50, their reasons for objecting is less because, things happen more frequently after the age of 50.
So you would say a CAT scan because you
CAT
had
scan. Oftentimes they'll start with
MRI.
So we'll start with a CAT scan, and oftentimes insurance will say, well, the MRI is a much more detailed exam. It's not as wide of I'm looking at everything. So a CAT scan will look at the liver, the pancreas, the stomach, the kidneys, all of the organs, and usually you'll do the whole abdomen.
CT, abdomen, pelvis.
Yeah, and they will look at everything. And, you might be thinking pancreas, and it might pick up something else in the stomach. And so a CAT scan is usually a first good step. Oftentimes they'll pick an ultrasound. And now ultrasound's not a great test.
That's why they kicked me up to the other test, which I had a meltdown. But the good thing is I found out you can wear glasses in the.
No, you're talking about MRI.
MRI.
You had a meltdown.
Oh, the MRI had a meltdown.
Ultrasound is an okay test looking at the liver, maybe the gallbladder, but it doesn't visualize the whole pancreas. So CAT scan first. If there's something there, then yes, an MRI is a better test.
So I have a question, which I'm kind of confused with, and I'm sorry if I do not understand this. So what about a detox drink? Is it good for recovering alcoholic with a fatty liver?
So I'm not big on specific products. I'm big on eating well and real foods rather than something that is processed or sold to you for the purposes of you need something. But again, acknowledging that you may not be able to get everything from food. some people may feel like I need something else, I need a supplement, but for the most part, our bodies will do well on most foods that you probably don't need an extra product. If you do, a multivitamin will probably do enough.
Really?
Ooh,
Well,
oh.
although
we gotta go to war
yeah.
with that one.
Yeah. Unless there is some
I
real
like
specific-
methylated vitamins.
There you go.
Well, I recommend a methylated product, methylated vitamin. Go with that if you're gonna do a multivitamin. That's it. But it's Dr. Fefferman and Dr. Huang show. Methylated.
Yeah.
Okay.
So, but I'm not specific recommending any specific vitamin or any specific supplement to detox.
Okay.
Well,
But
but
go
let
ahead.
me ask, I'm still doing my research. I'd be curious as to what you have to say. I'm starting to delve into peptides. So what about glutathione? Because I've been told like that can help to clean out your liver
Detoxifies
and your
your system.
pancreas.
Absolutely. But I think you have to do a work panel. You have to find out how much your system, because some people are doing 800 to 1200 micrograms a week on it. And I think it is bad, but I don't think you need a stack phase for it. So I believe as long as you stay within the six, and once again, this is just me talking, 600 to 800 range is fine because you're detoxing the body. I know me and you had discussed, what if you drink and you go and do the glutathione before bed? To me, it's still detoxifying, but I'm not a doctor and I couldn't tell you unless you're being tested for it, what it actually does. So that's kind of a hard question to answer. But I'm for glutathione. I'm for NAD. I think it's been proven and it works. It's just not FDA regulated right now.
Yeah.
So
I'm
wrong guy.
I'm still
How about
doing my
you?
research.
Yeah, I'll say it's outside of my space, but certainly we know that we give certain things to people who overdose, and we know take really high levels of toxic medications, say, and we do give certain detoxifying agents, in someone who
Activated charcoal.
well,
No, I'm just kidding.
yeah, but so, for example, what's called N-acetylcysteine for people who take too much Tylenol, and it kind of can help detox. Also, I'll use detoxify the liver in that specific case, but again, it's outside my real area of.
He's not
specialty.
saying use it. He's just telling you what it does. All right.
I'll leave that to you guys.
Don't leave it to me. There's two doctors sitting here. Can leave it to Cece, who's hidden. What do you got to say, Cece?
I'm just
You
listening.
had a lot of questions you wanted to know. Your
Well,
biggest.
I'm interested in early detection and what you do. I mean, how do you, what if you don't have the pain, you don't have some of those symptoms, but you're
Yeah, concerned. You say, yeah. So thankfully, pancreatic cancer is we'll say uncommon. But when it's there, when it is there, oftentimes we find it late. So we hear that people don't do well with it. Long-term survival when it's found late is very low. So early detection, we're really looking for what's the at-risk population. There's no current screening for everybody because there's the lifetime risk is only about 1%. So you'd have to screen people for a long period of time and tens of millions of people or millions of people to find one
It's
case.
crazy because Felipe knows so many people with pancreatic cancer.
Yeah.
Well,
Strange.
He
I
knows
have
like a
known
Really
dozen.
strange.
people with
Yeah.
it myself who just found it by accident
Yeah.
and miraculously, or however you want to put it, survived because
Yeah.
they found it by accident looking for something else.
Right. And those we certainly do find them. So again, if you have some symptom, and that's why I say the CAT scan is probably the best first step. If you have some symptom and you have a CAT scan, it may be picked up incidentally. We know that the baseline risk about 1%. They usually draw a line for where you should be screened when you're 5 times that, or about 5%. Because if you screen everybody, you're going to do a lot of screening tests. They're all going to be negative. Sometimes they might pick up something that is a false positive, meaning it says there's something there, but it's not really a pancreatic cancer. It's going to lead to surgeries in people who may not need it. So finding those people who are at risk, which are again, chronic pancreatitis, some genetic markers, and those are African Americans risk over 55, smokers, the genetic syndromes of the BRCA gene. Yeah. There's another one called Peutz-Jeghers, which is a polyp syndrome.
I was like KRAS, KRAS. It says it's found in 90% of pancreatic cancer cases.
Yeah.
Well, there's a new, I mean, there's, I've seen it advertised several times. There's a new test that you get your entire body scanned.
Yeah.
But you pay for it yourself, obviously. But you just go in there, they scan every single thing.
They do,
and
looking for,
I can't, to me, that's ridiculous
Yeah.
because you find false
positives. You may
and
expose yourself
cause
to
extra
radiation.
Yeah.
And there's some downside to that. So we don't want to do, first thing is to do no harm, and we don't want to over screen populations at low risk. We want to identify those who are at higher risk and screen them. So family history is a big thing. If you have one family member with pancreatic cancer at an early age, you probably should consider genetic testing. If you have two family members with, close family members on the same side that are close together, that's increases the risk. And we don't know every genetic mutation right now. So you can have two family members with pancreas cancer, and the genetic testing comes back normal, but that person may still be at risk because we don't know all the markers right now.
Well, for instance, in my family, there's no cancer on either side. None.
Yeah.
My grandfather smoked 52 packs of unfiltered Camel cigarettes a day, had lung cancer, but that's it. No one.
Yeah.
So it's.
So we don't usually recommend screening for the asymptomatic person, but if you do have symptoms, you should say, hey, I have symptoms. I shouldn't ignore these.
Well, how about if you have a hypochondriac like me who's like, well, what if I have cancer?
So your doctor will talk you off the ledge. No.
Yeah.
Well, I'm a recovering hypochondriac.
But at the same time, if you have symptoms, you should be listened to, right? Because
Well,
you may feel something, even hypochondriacs feel something. Their body is
Or they
saying
think they
something's
do.
not right.
They think they do.
And, oftentimes we will do a test and we'll do a negative test. And that's okay. A test that comes back negative is okay because it's reassuring. And it may give some sense of relief. Now the person comes back next week and says, well, I just had a CAT scan, but that was last week. Maybe something's new this week.
Yeah.
That's a different story. You need to develop the relationship with that patient. So, you together can be reassured and that there's nothing going on.
So I guess to summarize, so if you are in your 50s, have unexplained weight loss, or having some abdominal pain or new onset diabetes, and there's a family history, then definitely talk to your doctor. We can talk about either genetic testing, blood work, possible imaging.
Yeah.
Now, is genetic testing a definite, say you have the BRCA whatever genes, does that mean you're definitely in line to get something, or
it increases
it increases your chances? But if you don't have that BRCA gene, it also doesn't mean that you're not going to get it. Is that right?
Correct. So your baseline risk 1%. If you have BRCA without a family history of pancreatic cancer, your risk of pancreatic cancer is maybe 2 to 3%. So 2 to 3 times the baseline risk of someone else. If you have multiple family members, that risk can be high. So the screen or surveillance, meaning people that we look at who we consider high risk, who have higher than say a 5% lifetime risk, we will do an MRI yearly for people who are high risk, and sometimes alternating with a test called an endoscopic ultrasound, which is an endoscopy where we take a look down through the mouth into the stomach.
Sucks.
And the pancreas is right next to the stomach,
So
and it's an internal ultrasound that looks at the pancreas, and you alternate 1 year MRI, 1 year endoscopic ultrasound. Again, those are for those high risk, a genetic marker and a family history.
And what's your most successful treatment for pancreatic cancer?
Finding it early. So that's the main goal.
Other than
is
that,
finding it early.
Just
So I thought where you were going before was saying I see all these things either on the news. You can do a
Yeah.
body scan. Body scans are not mainstream because they're
expensive.
you may pick up things that are incidental and not necessary or lead to over treatment.
And
That-
I also I also worry that it gives people a false sense of security, because if it's negative,
I
then they're gonna be
agree.
like, oh, I had a full body scan last year, I'm fine.
Yeah.
So
It may not pick
could
up
go
something
either way.
early, right? So your CAT scan maybe give you a false sense that there's not something. The tests that an MRIs or having an endoscopic ultrasound every year. I mean, imagine if you're 50, you at some point after 10 years, now you're 60, you said, this is negative, it's negative. I'm tired of doing this. And then you stop. I think the future is going to be looking for a blood marker, which looks for a microscopic tumor marker or a small tumor cell or a tumor signal in the bloodstream. And this is where a lot of things are going, rather than having to physically look for something which may even be too small to see even on MRI.
Here goes my question. I was going to ask you about the AI and all this stuff, and you went all crazy on me.
That's the future.
There goes question. That question's gone, so forget that one.
So what about the Whipple? I mean, you were talking a lot about the Whipple, which I mean, I would presume at this point people know what it is, but
well, we can spell it out for people.
Yeah, I mean that would be,
You want to draw a diagram?
Sure, I'm happy to.
Oh boy!
All right.
Oh wow!
All right. So I'll draw a quick. I'm an excellent artist. I do this a lot.
I'm really good at Pictionary. Yeah. Wow, you are fat. Oh, that's okay. Wow, that's a big mouth.
Yeah. This is, as I said, I'm an excellent artist. All right. So eyes, nose, and mouth, esophagus into the stomach, and down here in the first part of the small intestines is where the liver and the pancreas connect. Your pancreas lives kind of right in the middle of your stomach. And when there is a pancreas cancer, say the pancreas cancer is here, because it's deep and it sits behind the stomach and it's surrounded by the small intestines, as well as the bile duct, which is the tube that drains bile through from the liver, you have to remove a lot. You have to remove part of the stomach. You have to remove part of the bile duct. You have to remove part of the small intestines and the part of the pancreas where the tumor is, and then you have to reroute things. So it's a really big operation. It's one of the biggest operations we can do. It's part gallbladder operation, part bile duct operation, part gastric bypass, and part removal of the pancreas. They oftentimes will leave the part of the pancreas that's not involved, which is the pancreas tail, but it is rerouting a lot of different things. So it's a big operation.
Jeez.
Yeah. But when you find an early pancreas cancer, it's necessary.
Now, as a primary care doctor, I have a question. So if you're removing the majority of the pancreas, does that put them at risk for diabetes after that?
Yeah, it does. I mean, most people, if the pancreas is in the most common area, which is called the head of the pancreas, they'll remove that and leave the tail. The tail oftentimes will produce enough insulin that they're not a diabetic if they have to remove almost all of the pancreas or all of the pancreas, which is not the usual, not the norm. Then most people are not diabetics, but it is a slight risk. Pancreas also makes some digestive enzymes, so it does put you at risk for not making the correct amount of digestive enzymes.
Well, your uncle had it, 4 years ago now?
It's 3 years now. 3
Yeah,
years.
he's doing
Yep.
great,
And then
so.
it was 2 years after my other uncle was diagnosed, which is strange. They both are on the
Two
same.
brothers.
Two brothers.
Yeah.
One after another. The other one dealt with his pain and didn't say anything to anyone about it. And then finally couldn't handle the pain anymore and fell over. And he's been having pain and throwing up for over 2 years, but never told none of us. So kind of hurtful. But let me ask you something. So I was listening to everyone speaking in here, and there was a question I wanted to ask you. So I was looking at, and I do apologize. How long have you been in the practice that you've been?
So 20 years, 21 years.
So 21 years, and I love that. So thank you so much for your service. I appreciate that. So when you look at today's lifestyle, right? Alcohol, fast food, constant stresses, do you think we're heading towards a generation? So I'm trying to figure out of a higher pancreatic disease type of thing. Like, are you seeing?
I love my charcuterie boards.
Yep, and that you do everywhere we go. I need to get one. Nope, that's not a real one. I'll buy more stuff. Which my sister made you a killer one too, by the way, that you finished off. But what do you feel about that? In 20 years, have you seen such a change in generation?
So we're seeing an increase in a lot of different cancers. And
cancer in 20s.
Yeah, I mean, so we're seeing, we're seeing as we all get heavier, a lot of more metabolic stress.
Speak for yourself, Dr. Fefferman. Speak for yourself.
Yeah.
Me and the doctor dying, and we're going to Mexico, so we're getting shredded.
But we do know that pancreatic cancer is on the increase as well. It's especially pancreatic cancer, deaths from pancreatic cancer are unfortunately going up.
Well,
So-
environmental
So, but-
factors and food.
Yeah.
Is that because there's a rise in number or because of late detection or combination?
We are still, I mean, the goal is to detect them earlier, but we're still detecting them late. And that's the main problem. So anyway, we can.
So you
detect
haven't
them
seen
sooner.
any changes in detection in like your practice, like moving forward and using different types of things to detect it, I guess, per se.
So we're definitely using CAT scans more. We're definitely more aware of it. So someone comes in with symptoms, we will oftentimes go right to a CAT scan. You
And
know,
what's the percentage of it being found on a CAT scan?
it's really rare. I mean, it's well, if
Can it be
for
missed
every
is my
CAT
question.
scan, so can it be missed on a CAT scan? The answer is yes, it can be missed. It can be very small or very subtle. You can miss it on MRI. You can miss it on endoscopic ultrasound. So those who are at high risk, that's why they need to be looked at yearly. If there are subtle changes, sometimes we look at, more frequently.
So here's to give you perspective, and you can tell me if these numbers sound right. So I've been in practice for about 20 years, and I right now have about 3,000 patients, and I think I've had 2 patients with pancreatic cancer. I mean, do those numbers?
Well,
sound
add
right?
two more, my uncles. They're not
No,
your
no,
patients,
no,
but
yeah,
you
right.
kind of
But that
oversaw
I've had
this
in my
stuff.
practice.
They confided in you.
So not
Yeah.
that.
I mean, you will certainly see much more lung cancer, breast cancer, colon cancer, skin cancer, prostate cancer, ovarian cancer.
Mhm.
Those are much higher. Thankfully, those are oftentimes found earlier, or when they're treated more effectively. Pancreas cancer is it's one that is a little bit more vague to pick up, and oftentimes when we pick it up, or even when it gives patients symptoms that they can actually put their finger on, it's oftentimes late. So even when we do pick it up, when someone says, "Hey, I just developed these new symptoms," we will pick up an advanced cancer that we can't cure,
Yeah.
and that's the difficult thing. That's the difficult thing. We don't have great ways of picking it up when it is curable.
So
What is the survival rate, would you say, for pancreatic cancer?
So,
As is now.
yeah, so it's the 5-year survival rate for pancreatic cancer is low. It's on the order of 10%. Now, those are averages. So someone who may be watching or listening who has pancreatic cancer, that shouldn't, they may have a fight ahead of them, and
You
you're
got
not a
this.
statistic. Yeah,
you got this.
You're not a statistic. You're an individual. So
Right.
fight.
Well,
Pick up the
That's,
Bible.
Everyone's different.
Yeah.
Everyone's gonna survive
Yeah.
differently.
Younger people tend to do better. They're stronger. They're hopefully we're picking it up earlier. But again, it comes down to, if you have symptoms, talk to your doctor, talk to your provider.
Well, I think that patient education is most important.
Yeah.
In any cancer or any disease.
Now, when your uncle was died, there's an option, Whipple or I think chemo, right?
Yeah, chemo, radiation. They
Yeah.
wanted to offer both of those. And my other uncle did do both of them, Santos, if you remember.
Mhm.
After he had the Whipple, they went in and did the chemo and the radiation, and then he completed it. So God willing, he beat it. So
Yeah.
I just want to say something from just my final thought, because I wanted a question and I made sure I put it in. So what's one thing people can do tonight to lower the risk of ever facing this disease? Is there a possibility?
So living a good, healthy life. If you're a smoker, smoking's not good for any condition. So if you're a smoker, quit smoking.
Hear that, someone? I'm not going to say your name, but you hear that? That's out to someone.
Uh,
I think it doubles your risk of
Yeah.
pancreatic cancer.
Alcohol, alcohol can have some beneficial effects, but for a lot of times we use it as a crutch for different things. So don't use alcohol to excess. Moderation is one thing, but alcohol as a crutch, probably not a great thing. Eating healthy, watching your overall, your health, your metabolic stresses, and then awareness. There's some great organizations. They have some, even on the Pancreatic Cancer Awareness Network, or pancan.org, they have some health screening things that you can click through and say, what's my risk? If you do have a family history, make sure people know. A lot of people don't like to talk about cancer in their family, but family members should know, because if there is a genetic predisposition, or if there's a potential genetic abnormality, genetic testing might be correct thing to do if you have more than one family history or family member with pancreatic cancer. So awareness And then again, be your own advocate, be your family member's advocate. My mom's losing weight. I should take her to the doctor. Why is she losing weight? She doesn't want to bother anybody. Well, you want to find out earlier rather than later. So early detection can save lives.
I appreciate that answer, Dr. Fefferman. It really means a lot, especially with my family going through these things.
Yeah.
Any questions from anybody else?
Can I echo what Dr. Fefferman said?
Absolutely. I wasn't going to close out. I was about to say at the end of it, Dr. Wynne Huang, since you gave us this opportunity to have Dr. Pefferman on, since he's an old colleague.
Thank you.
Right?
Not
Thanks for having me.
old.
An old
Seasoned.
season.
Yes.
Yeah.
Well, I would like to offer him a piece of candy first, please. I let everyone grab a candy out of it, and then you didn't jump. Forget it. You didn't jump. It's not forget it. Forget it. Go ahead, Dr. Wong. It didn't work the way I wanted to. That sucked.
So I discussed this last month during the Breast Cancer Awareness Month podcast. But the holidays, like Dr. Fefferman was saying, no one really likes to talk about, family history, cancer and stuff. But it's a good time. You're going to be around your family and just be like, it is important. Like, is there a new family history of any cancers? And also it can be cross. So, you have a prostate, if you have prostate cancer, you could still get screened because the BRCA2 mutation can cross over to breast, ovarian, pancreatic. So, it's important to know all of your family history.
And I would like to just add to that, Dr. Wong did an incredible job. We went and had a recovery party for my uncle. But she brought in a bag of genetic test kits that kind of threw off everyone.
Yeah.
She was like, while everyone's celebrating, drinking, she goes, "Here, have a box. And everybody's like, "What the hell is this?" And I'm like, "She wants you to get tested. Swipe it now."
But
so it was funny.
Yeah,
but
for the
it was,
saliva test, you can't eat or drink any or chew gum for 30 minutes. So
yeah, which everybody was drinking.
Yeah.
So hence the term.
Well, no, anything like Coke or like anything, like nothing in the mouth for 30
Coke?
minutes. Like Coca-Cola.
Oh, Coca-Cola. Okay, I wanted to make sure.
No, I'm saying you can't. It's not alcohol, but you can't have anything in your mouth for 30 minutes beforehand.
Did you hear that, everyone? Nothing in your mouth for 30 minutes when you're swiping.
Oh, okay.
When you're swiping.
It's spitting, actually. You're spitting.
Oh, okay. I didn't know. I thought you said swipe it. So it's the same thing. So once again, Dr. Pfefferman, I appreciate
Absolutely.
it. Thanks you so much, Dr. Wong.
Would you like to come back for colon cancer awareness?
Yeah.
Is that March?
What are you looking
March.
at me for?
March. Yeah. March.
Back in March.
I don't know dates and months.
And that's teal. Pancreatic is purple.
Oh. So once again, thank you everyone for joining us. If you guys have any questions, feel free. We could definitely get them out to Dr. Pfefferman. I really appreciate it. And thank you everybody on Facebook. And thank you for the question. But if you still want, you can still ask questions and I'll load them up. Thank you, everyone. Have a blessed day.
Thank you.
Thank you.
Thank you.
Can I go to the bathroom now?
No.
Nope.
We're still live, Cece, so you can't go to the bathroom yet. Hold on. Cece's got to go to the bathroom, everyone. Thank you. End stream. Now you can go
That
to
was
the
awesome.
bathroom. We ended.
Thank you.
No, thank
Except
you.
nearly dying on my